1, the instance of the major bleeding increased if the OAC continued. And also, the CHAD score 2 instance of major bleeding increased, significantly increased, while there was no difference in the thromboembolism. If the patient has a CHAD score equal or greater than 3, the thromboembolism risk decreased without the increment of the major bleeding. So let's move to our study, Ryoma Registry. This is a follow-up study after the AF ablation. In this study, DUAC was used in the 95% of the patient, and warfarin was used 5%. This is a result of the main study. During the follow-up, the thromboembolism incidence is extremely low in the warfarin and the DUAC groups, and in the major bleeding, warfarin group showed a significantly higher major bleeding compared to the DUAC group. And then now we perform the sub-analysis, and this is a DUAC continuation rate after the AF ablation. And this figure shows the serious adverse events per year of follow-up after the ablation. And this is the event while taking DUACs, and the right panel shows the events while not taking DUACs. And the blue bar indicate the instance of the ischemic stroke or systemic embolic events, and the red bar indicates the major bleeding events, and the green bar indicates the all-cause death. When we see the events while taking DUACs, in the patient group, CHAD2 score 0 to 1, incidence of the major bleeding is significantly higher compared to the ischemic stroke. In CHAD score 2, the same, the incidence of the major bleeding is significantly higher than the ischemic stroke. But patient group with a CHAD score 3 to 6, there was no significant difference. In the events while not taking DUACs, the event rate of the ischemic stroke and major bleeding is extremely low. When we exclude the patient having the antiplatelet therapy, the trend became much more clearer. Here, again, the incidence rate of the major bleeding is significantly higher in CHAD score 0 to 1, and also the incidence of the major bleeding is significantly higher compared to the ischemic stroke in the CHAD score number 2, and in the patient group, the 3 to 6 CHAD score, the incidence rate is comparable. In this result, the CHAD score 2 should be considered as a low risk. However, if the patient had a CHAD2 factor, there is difference. If the patient has a S factor, stroke history, there was a highest incidence rate of the stroke. That means that if the patient had a CHAD score 2 with a stroke factor, that should be considered separately from the another patient with a CHAD score 2 by the another factors. So sub-analysis number 2 is the analysis of the off-label underdose and the off-label overdose. We classified into four subgroups. Number one group is the on-label standard dose, A second group is off-label underdose, and the third one is on-label reduced dose, and the last subgroup is off-label overdose. And this is the proportion of those categories by each DUACs. And the dabigatran has a little bit higher proportion of the off-label dose. And this is a ischemic stroke and the major bleeding during the acute phase up to the 30 days after the ablation, and the remote phase from the 30 days to the 1 year. And in a ischemic stroke systemic embolism events, there was no significant difference among the subgroups. However, about the major bleeding events, off-label overdose group has a significantly higher incidence of the major bleeding. So this is the comparison of the factors, and predictive factors of the major bleeding is a history of the major bleeding and the DUAC overdose and old age over 75 years. So therefore, the off-label overdosing of drug should always be avoided. So recently, the very good paper has been reported. The principal investigator is the chairman, Professor Boyonjang. And in this randomized clinical trial, they randomized the two arms. One is a continuation oral anticoagulation using apixaban and rivaroxaban, and the another one is no anticoagulation group. And this is a result. This is a composite outcome at the 2 years. Continue oral anticoagulation group has a 2.2%, whereas the discontinued group has a significantly lower incidence of the composite outcome, 0.3%. No DOAC treatment resulted in the lower risk of the composite outcome. And the 70% of this study had a CHAS-BAS score 1 to 2. And this is the ischemic stroke and the major bleeding. Although there was no significant difference, but up to the 18-month, oral anticoagulation group has a little bit higher incidence of the stroke. And after the 18-month, oral anticoagulation group has a significantly higher incidence of the major bleeding. As a composite outcome, oral anticoagulation group has a significantly higher primary outcome compared to the no oral anticoagulation group. They also did a subgroup analysis, and the no DOAC, no anticoagulation is preferable, especially in a patient with the age over 65 years and the male, and no diabetes, and no previous history of the stroke, no vascular disease, and has blood score equal or greater than 2. However, in this subgroup analysis, there was no trend in the CHAS-BAS score. That means the CHAS-BAS score cannot be a factor of the decision making to discontinue the OAX therapy after the AF ablation. So this is the ongoing randomized trial named the Ocean trial. They also randomized the two arms, and one arm is a rivaroxaban group, and the another one is aspirin. I think this may be the limitation of this study, because a lot of study already mentioned that the aspirin is one of the predictor of the serious bleeding after the AF ablation. In summary, ladies and gentlemen, thromboembolic risk factor AF ablation is generally low, and the major bleeding risk remains a key concern, especially with warfarin. And DUACs are safer than warfarin, but the continuation should be individualized. And the low to moderate risk, for example, CHA2 score equal or less than 2, or continuation increase the bleeding without a clear benefit. And the high risk, for example, the CHA2 score equal or greater than 3, or continuation decrease the thromboembolism without the increment of the bleeding. Off-label drug overdose should be avoided always, and the ALONE-AF trial showed the composite outcomes worse in the DUAC continuation group, and the OCEAN trial result awaited. Thank you for your attention.